Good afternoon, everyone. Thanks for joining us for Advanced Echo Teaching today. We'll go through about ischemic heart disease, basically regional wall motion abnormalities, and then we're going to move on to talk about some of the exciting myocardial infarction complications. Once again, commonly asked exam topic, and it's good to have a broad overview, I guess, of everything involved, particularly the MI complications. Okay, so we'll go through all of those. At the start, let's just say purely from a clinical point of view for those who are starting out, echo is really great for trying to look for ischemic heart disease complications. And regional wall motion abnormalities would be one of the obvious ones that slips into mind, as well as LV function analysis, and then all the other complications thereof. But it's not great for ruling in or out whether you've got horrible complications. And it can give us an idea. I guess maybe it's a little bit like a PE assessment, that it can give you an idea. You can certainly start seeing horrific complications from it, but it's not perfect, but it's great for that initial assessment and can certainly help you when the patients are getting really, really sick. In regard to the serious complications that we're going to have a look at, clinical acumen, I find it is absolutely essential for these. You've got to have the idea there are complications in mind, because if you just stick with standard imaging, you could easily miss them, and we'll talk a little bit more about that in a moment. So let's start off by talking about just simple regional wall motion analysis, and I should say that I think this is one of the harder things to do in echo because it's so subjective. And so the first rule of thumb would be that you've got to know your anatomy, you've got to know your walls, because you get at least 2 bites of looking at every single segment. I use a 16 segment model, others use a 17 segment model, but you've got to be able to assess each and every one of those as you can. And if you can't see it, say you can't see it. It's okay, because I think it's very hard to get all 16 segments in a critically ill patient sometimes, particularly for the anterior ones maybe. But you normally get 2 bites of the cherry. For example, let's say looking at the anterior wall, you can see it in your 2-chamber view, but you can also see it in your parasternal short axis. And that's always my go-to view for trying to look at regional wall motion abnormalities. And I always have it like a clock face, so that you're looking at either the segments that are above and the segments that are below. And again, we can talk about that in a little bit more, but trying to compare it like a clock face and being very systematic in your analysis is really important. I say don't forget the subcostal view. Here you can see the little loop that's in the bottom of the image there. That's a subcostal short axis view. And we talk about the subcostal view being the intensivist's best friend, or the emergency medicine doctor's best view, because you've got the liver in there, which means it makes it a much larger acoustic window for you to have a look at. And you can get quite a lot of information from it. And I learned all of this from our wonderful sonographer here at Nepean called Jenny, who's the queen of subcostal views, and she can do the most incredible amount of analysis from that. And this would be an example of how to do it, where you're subcostally, and then you just rotate your probe around and look to the patient's left, and you can get pretty decent short axis views if you're lucky. And including this, you can also get analysis via RVOT sometimes, and even a tricuspid valve. So don't forget the subcostal view for your 4-chamber view, but also for your short axis. What about acute versus chronic? So how can we determine acute versus chronic in ischemic heart disease? Lewis, do you want to have a quick crack at this? Talk to me about acute versus chronic in regional wall motion abnormalities. So how can you determine the difference? If you're seeing something that's not moving, how might you say if it was acute versus chronic?
Yeah, so ideally you'd have a comparator.
Nice.
And that you'd be able to see old echoes, not always possible. The presence of thinning or scarring is a feature of chronicity.
Beautiful. And scarring, just again, for those just starting out, what do you mean by scarring? What does it look like on an echo?
It looks hyperechoic.
Beautiful. So yeah, so acute is something that's not moving, but it's the same thickness as other parts of the myocardium. Chronic, it would be thinned and echogenic. Very nice.
Yep.
Hatton. What do I mean by if the apex is akinetic, and this is just tips and tricks, if the apex is akinetic, complete the sentence. What am I doing?
What's the question?
The question is, I want you to finish the sentence. So the final part of the tip and trick for regional wall motion abnormality. If you see an akinetic apex, ... what do you have to do?
So first you have to confirm it from different views.
Yeah.
And then after that, you have to check what's exactly, whether there's any underlying aneurysmal dilatations.
Yeah, nice. And what are you worried about if there's aneurysmal dilatation?
So you would be worried about left ventricular apex thrombus.
Beautiful, beautiful.
Yeah,
Fantastic.
and that's where, yeah, and you have to make sure that you're not missing any other pathologies like reverse Takotsubo.
Okay, sure, yeah. Remember, akinetic apex would be to be a standard Takotsubo, right, rather than reverse. But I hear what you're saying. The most important thing is to look for the thrombus that's sitting in the apex. So that's
exactly.
Off-axis imaging, search from different views, fan through the whole of the apex. Yeah, so if you've got an akinetic apex, don't forget you've got sluggish blood flow, check for thrombus. Very nice.
Yep. I got a recent one, by the way. I'll show it to you.
Oh, I'd love to see it. Well, bring it on to the next group. I'd love to see more cases from people. It'd be great. Hatem, while we've got you on, so here's a parasternal long axis view. What walls do you see to the left?
Sam, I'm driving, so I can't see.
Well, what are you talking about? There's priorities here, Hatem. Crikey. Ravi, how about you? Are you driving?
Jesus.
Pull over. Yeah. No, I appreciate the dedication to echo teaching, by the way. I do appreciate that. That's above and beyond. It's being recorded. Ravi, are you there?
Yes. I'm in a car park, but I am still, so I can't talk.
You guys are amazing. Guys,
So,
do you want us to put do we put teaching to a different time? Is anyone not driving?
It's a parasternal long axis, so it's anteroseptal and inferolateral.
You're the man. You're the man. All right. Where are we up to here? Sorry, I forgot to loop it. We've got an apical four-chamber view. What walls are we looking at here? Beautiful, beautiful. Okay, that's exactly right. If you can say it quickly, again, in the exam, we had the exam this weekend. This came up again. You got to say it. You don't have to say it as quickly as that, but that was pretty good. Just say it with confidence and get it right. Beautiful. So when we're talking about regional wall motion abnormality, we got to know what walls we're looking at. We got to look at all segments we can in two views if possible. And then you've got to say it's either normal, hypokinetic, akinetic, or dyskinetic. It's not mildly hypokinetic. It's not hypo to akinetic. It's not dyskinetic. It's to aneurysmal. Aneurysmal's not in the new guidelines. So it is one of these things. I guess this is another one of my pet peeves is, you know, slightly hypokinetic or something. It is or it isn't. And that's based on whether its thickening fraction is less or greater than 50%, okay? And akinetic is not moving really, and dyskinetic is moving in the wrong direction during systole, okay? So just try and have those labeled in your heads. Two ways to try and remember. The next thing is the blood supply to the left ventricle. So it is variable. I think anyone who's done any coronary CT would tell you that the regional wall motion abnormality is far from straightforward, and the LAD is going to supply that. I always have it as I sort of hold my fist, and the LAD is the fingers are the apex, and my wrist is the base of the heart. LAD goes across the top, coming around the side. The right ventricle's at the side, maybe not going completely around the apex. And the circumflex is all underneath, and it can vary considerably. All right. With that, you must then have an idea of what views you're looking at and what walls. And so with these two slides, maybe you could sort of put them together to try and understand where the LAD territory, circumflex, and right coronary artery can affect. So I think it's in this cartoon, I guess it shows that the right coronary artery is supplying the right ventricle in entirety, and sometimes I find the circumflex can get involved in that, and even the LAD can probably also do some of the apex of the right ventricle. So it's variable. Maybe this cartoon is not perfect.
Question.
Yes.
If you suspect RCA territories, would you expect the right ventricular function to be impaired?
Yes.
So if it's not impaired, would that go against
Absolutely not.
us? Okay.
No. Because I reckon, as I was just saying, I think you can have blood supply from other areas helping you.
So it's
And I'm
not
particularly thinking of my cardiologist friend who, you know, I think every intensivist who's learning advanced echo needs a cardiology friend to give them pearls and pitfalls. And his one for me was regional wall motion abnormality, and he says it doesn't. It guides you, as I said. It doesn't help rule in or rule out anything because it is such a variable feast of supply.
Okay. So when you see it, you just describe the segments that are involved.
Yeah.
Rather than do you make a conclusion about which?
I do, and we kind of went through it. I was going to put in a case, but we did it last week, I think, for the DDU cases, so I didn't add it in. Of someone, the example was, it was a 65-year-old gentleman. He was admitted under respiratory, and he was short of breath. And so echo was for assessment of that. And looking at his echo, he had inferior basal and mid-wall hypokinesis and a right ventricle that was down but not dilated. And so in the conclusion, I said, we've got these regional wall motion abnormalities. It looks potentially to be acute, and I use lots of the word like potential, maybe, but I said it's potentially acute because it's not thinned and scarred. And the right ventricle being down suggests there might be right coronary artery territory involvement, maybe circumflex, you know, suggests cardiology review. And that guy did have actually some acute ischemia, and they looked at the ECG a bit more carefully, and, you know, right coronary non-STEMIs can be easy to miss, I think. And so that time echo did sort of point in the right direction. So I do, when I'm writing my reports, I talk about hypokinetic or akinetic or dyskinetic segments. In the conclusion, I try and say that there's a, you know, this suggestive of chronic ischemia in the LAD territory potentially. You know, so I do write that in there just to try and help guide you. If it's for a cardiology person, I obviously probably don't try and tell them how to suck it and don't tell them what coronary artery territory is. But so I do try and do it as long as I'm not saying it's definitely this. My stuff. Okay, Lewis, the anterolateral rule can be assessed in which view? 1, 2, 3, or 4? Are you on that, Lewis? What are you thinking?
Sorry, mute. 2.
2, before jump. Beautiful.
I was very quick, just so you know. Just on mute.
Nice. All right, Lewis, stick with it. So what views are we looking at here on this toe image? And tell me what you see.
So you can see the appendage there. So that's the mid-esophageal 2-chamber.
Very nice. So which wall is which? So what's the one on the left, closest to number 10?
On the left, closest to 10. So that's that's inferior wall.
Inferior. So the other one next door to the left atrial appendage, because the left atrial appendage is always sitting up at the top, so that is the anterior wall, right?
Anterior wall.
Cool. What do you think about the regional wall motion abnormalities?
You're getting a bit of dropout from the annulus there, so it's a bit hard to assess anything but the apical segment of the anterior wall. But it looks like the apex is not contracting well, and the anterior apical segment's not contracting well.
Excellent. And just if we're going to try and stick to the definitions rather than saying it doesn't contract well,
Yeah. They look akinetic.
Fantastic, beautiful. So I don't think we got any, and this was missed unfortunately on the echo. And this was an example of a toe that was done for infective endocarditis. And just the tip and trick I guess I learned from this was that, again, you can have multiple pathologies going on. I'll show you this echo sometime when we talk about infective endocarditis. It's absolutely astonishing. But the importance is that you can have multiple pathologies going on. You can have multiple valves involved in infective endocarditis. Don't forget, this is the importance of that systematic approach, right? Because this person had an embolus that was thrown off down the LAD, and this was the first possible indication, maybe in her stay, that had happened. And potentially, I don't think it would probably change the outcome, which was horrific, unfortunately, but it might have at least done it a little bit earlier. It wasn't perfect. But so yeah, multiple pathologies can come on even when you're on tow looking at the valve. Don't forget to look elsewhere. And this is a great example of apical, akinetic, apex, acute. It's not thinned and scarred, just standard thickness, but not moving at all. Akinetic. Very nice. Okay, let's talk about complications. I spent way too much time trying to find little cartoons for each of these things. So anyway, these are the complications I could think of. So what are all of these complications? And my favorite one is the bottom right. So hit me with the complications of myocardial infarction that we need to look for on echo.
So immediate, mid-term, long-term. So that's what our
Okay.
thing. So immediate complications depends on what coronary artery is involved. So that's important. And if we just go through quickly, then systolic dysfunction.
Nice.
Severe valvular dysfunction.
Yeah.
Mainly regurg, and sometimes there's papillary muscle dysfunction or rupture, which causes acute regurg.
Yeah, which one's that one, by the way? You're not going to get this. You don't even swim, so you're not going to get this one. Which one is it? It's this one. Is it, why is it that one? Do you know who that is?
You're asking.
Does anyone know who the bottom right one is? It's one of my heroes.
I don't know how to swim, and you're asking.
You're never going to get it. He's like he's one of the best surfers who sort of kicked everything off. His name's Mark Richards, and all his surfboards have a big MR on it. And he's an amazing surfer. So anyway, that's Mark Richards, which is mitral regurg.
Why did you make that choice?
Well, you know, maybe there's no someone who surfs that. I don't know. Beautiful. So yeah, acute mitral regurgitation, beautiful, nice.
And other RV dysfunction and long-term complication in terms of LV aneurysm, pseudoaneurysm, and irreversible LV dysfunction, and
Nice.
arrhythmias, and all those things.
Beautiful. So I had
And sorry, ventricle septal defect, rupture, and that's common.
Nice. So I had the little cartoons going from maybe 12 o'clock round. So first of all, that's shock. You can have, acute LV dysfunction. Obviously, we see that with LAD territory infarction and sticking in balloon pumps. So yeah, shock. Dressler's syndrome. I was thinking with the top right one there, you get a bit of fluid around the heart. Maybe it sort of comes on with a bit of pain. I think it's worse when you're lying down flat. It gets better with non-steroidals. Gets worse when you sit up. Typically with 3 days after an infarct. Acute MR, as we talked about, a valvular dysfunction, that can be papillary or tethering, and we'll talk a little bit more about that in a sec. Thrombus, such as Hatim was telling us about, with an akinetic apex, and then again, typically 3 to 5, 7 days down the track, you can get ischemic holes in the heart forming, and they can be VSDs, they can be free wall rupture, and then the top one was heart failure. And yeah, my second thing.
Did you Google failure?
Yeah, I googled failure and I googled heart and it was really boring, and then I googled failure. Sounds good. Okay, where are we up to? Sid, hi Sid, are you? Can you hear us? Or does Hatim, you're still driving?
I can hear. Yes, sorry, I can hear.
Hi Sid, are you happy to take an MCQ?
Yes, why
I'm
not?
trying to focus a little bit more on MCQs now the DDU exam is done. Just for those who may be doing the American Echo Board exam soon. So which is the most common complication of myocardial infarction? VSD, ruptured pat muscle, tamponade, or regional wall motion?
Regional wall motion abnormality.
Yeah, beautiful. Which would be second?
Ruptured pap muscle.
Yeah, good man. I think the same. Yeah, so VSD and tamponade are extremely uncommon and bad signs, and ruptured pat muscle is also pretty uncommon. Whilst we've got you on, okay, we're talking about acute pat muscle rupture from MI. Which of the following is true? Is it 1, the anterolateral papillary muscle is most likely affected? 2, acute MR flows in the opposite direction to the area affected of ischemia? 3, right coronary occlusion is the most likely culprit coronary artery for an acute muscle rupture? And 4, it is a relatively benign complication from an infarct.
Most likely 3.
Okay, hang on. Talk to me about 1. So why is 1 wrong?
Depends on the coronary artery involved, I would think.
Yeah, so
Anterolateral
often, which PAP muscle only has a single coronary artery supply?
Okay, right. Anterolateral papillary muscle.
Yes, the posteromedial, which is supplied by the circumflex coronary artery. So it's typical with circumflex acute ischemia that you can get rupture, which is classically, unless you're getting sort of two territories or you've got some unusual coronary artery distribution, the most common one they talk about is the posterolateral papillary muscle getting blocked by the circumflex. So that's why one is wrong. And number two, for number three, then it's not the right answer because it's normally the circumflex artery, which is the most likely culprit coronary region for PAP muscle rupture. It's obviously a horrific complication when it happens. And so it's number two, which is actually correct. And that's for these reasons. So we'll just go through A to E across the track and hopefully this will answer the questions. So number A is normal. I'll start that one off. Why don't we have a go at some of the others? So what's the cartoon in number B trying to show? So that's when you get central MR. What can give you a central mitral regurg? And I guess this is not just in myocardial infarction, but say this is chronic infarct and you've got what's happening to the LV?
Most likely dilated mitral annulus.
Beautiful. And now we're going to come to number C. So say we've got ischemia and you've got an ischemic akinetic area. What's number C trying to represent then?
Probably showing the dysfunction of the posterolateral intraposterior papillary
Nice.
muscle.
And what's happening to mean that the MR is going in the same direction as where the ischemia is? Do you remember what that's called?
In the same direction.
Yeah, we call it tethering. So if you get ischemia and you start to have that papillary muscle that sort of contracts down, you can get a contraction through the chordae. They can all get pulled up. So that valve then doesn't close properly. And if it doesn't close properly, you get MR going in the same direction. So typically that's a very common feature that we might see from ischemic MR, they might call it, where you're getting eccentric MR and it's in the same direction as the wall that's being tethered. What about number D, Vishal? So you were talking about this before?
So I think it's kind of Carpenter classification.
Very nice.
And so excessive motion in this, which is showing the rupture of the posteromedial muscle.
Yeah, another word for rupture?
Prolapse or flail.
Hang on. So this is flail. When you've got the tip of the mitral valve leaflet pointing away from the apex, flail. And so the last one where the tip is pointed towards the apex is prolapse. Beautiful, okay? So just try and get those different MR in your head. And particularly with ischemia, I guess it's sort of C to E to try and think of in terms of tethering, flail, and prolapse. All right, so you're called to see an acutely hemodynamically unstable 70-year-old 3 days after suffering a STEMI. Angio found 90% LAD artery stenosis and 100% circ artery stenosis. Which of the following is least likely? LV dilation, VSD, mitral valve prolapse, posteromedial PAP muscle rupture. Who wants to have a crack at that? Which one's least rupture? Which one's least likely?
So 3 days.
3 days. 70-year-old female. She's hemodynamically unstable. Maybe this is a bit of a rubbish question, to be honest. Yeah. Let's say she had a normal LV.
We've just spoken about the blood supply to the papillary muscles.
Yep.
And so posterior medial papillary muscle should be spared with a LAD lesion.
But we've got a circ in there as well. You've got 100% circ.
Oh, sorry, I didn't read that.
So I guess it could be the posteromedial PAP muscle rupture because you've got the circ involved. That can give you mitral valve prolapse. The reason why I said it's a bit rubbish, I've also added in VSD. These are all kind of really rare complications. I guess what I was trying to get at was in the acute setting, you probably don't get LV dilation. If you're going to get acute changes and acutely hemodynamically unstable, that's not LV dilation. But on the flip side also, it's probably the most likely chronic problem. So you're probably more likely to see LV dilation than you are any of these others a week's basis. But anyway, that's what I was trying to get at with the question.
Just
It's a bit rubbish.
one comment. I think you mentioned that the posterior medial is supplied by CERC, right? It's CERC or RC.
Fair enough. I think you can say that, but it's you normally got a single blood supply. Should we
Posterior
say?
descending artery, either which is a branch of RC
Absolutely.
or branch of.
Absolutely, I think, absolutely. That's probably better. It's the only one that's got a single. The anterolateral's got the double supply. All right, let's do a case. Lewis, do you want to have a crack at this? So, Met calls for a 58-year-old lady, and this is before she's even had her angiogram. She's had a non-STEMI a few days ago with troponins up to 6,000. She's blah blah blah. Don't worry about that. She came down 3 days after having this non-STEMI to have an angiogram. She's a smoker. She's a hypotensive, and she's on some medications for hypertension.
Yeah.
Tell me how well this comes through.
Yeah, it's okay, I think. So it looks like the LV function is globally moderately impaired. Left atrial size is enlarged. The RV function looks like it's okay, but I'd like to see that in another view. The mitral valve is indistinct and difficult to appreciate, but seems to have excessive motion, particularly of the anterior mitral valve leaflet. I can't say much more of that. All
right, give me what walls can you see in this view?
This is the anteroseptal and the infralateral.
Beautiful. And just talk to me about the regional wall motion abnormalities.
So
just compare one segment, the two basal segments, compare those, and then compare the two mid segments.
Yeah. So it's a little bit hard to see, and I'd like to see it in short axis. It looks like the infralateral wall is severely hypokinetic.
Hang on. Tell me about hypokinetic. What's the? Do you have severe, mild, and moderate hypokinesis?
No, you don't.
No, it's either hypokinetic or it's akinetic.
It's a bit of a hedge.
It's a massive hedge. That's that.
I think I can see some thickening there, so I'm going to call it hypokinetic.
Sweet.
And then the anteroseptal wall is moving, but it's a bit hard to know whether that's translational movement or thickening.
Yeah, fair enough. It's good thickening.
And there is posteriorly directed MR that just on the basis of the vena contracta looks like it's probably severe with a significant amount of flow acceleration that's wall hugging.
Beautiful.
Yeah, so this is short axis. So you can see here that that there are regional wall motion abnormalities, and the inferior and infralateral wall are hypokinetic, as well as the infraseptal. In fact, I'd probably say the inferior wall's akinetic.
Great.
And the anteroseptal wall looks like it's got normal contraction.
Anything else jumping out at you?
So I'm looking on my phone, so it is a bit small.
Let me try this one.
Actually, no. It looked like if that was a mid-pap view, then I think one of the papillary muscles might be missing.
Yeah, very nice. And we'll just go down to the. This might be a little bit better in this.
Yeah, so this is the mitral valve view, short axis. It looks like there is excessive motion of the anterior mitral valve leaflet.
Yeah, beautiful.
Yeah.
I found this case a really good example because I think they classically, when I was learning about this, they talk about the, when you get acute rupture of the posterolateral papillary muscle, it gives you anteriorly directed MR. That's the way I learnt it. And well, I think this is a really beautiful example, and I think it was again demonstrated really nicely in a lecture Vishal gave on mitral regurg, you've got to remember that each papillary muscle gives attachments to both leaflets. And so this is the anterior mitral valve leaflet that's then just flopping around all over the shop with the flail, and it's leading to a posteriorly directed jet. So it's just reminds that the PAP muscles supply both leaflets of the mitral valve. And so just like you were saying, it's got a really nice, it's probably more of a, you can see it now, the massive papillary muscle is just sort of wibbling around there in the left ventricle with the akinetic lateral wall, giving you that massive, beautiful Coanda effect there with its huge vena contractor and Pisa and chaotic blood flow, and that eccentric MR, just like you said, is severe. Who else have we got? Sid, Sid, what's this next one show? What's this view here? Be really, is it an important one? Probably not so much for ischemic heart disease complications, but what's this slide show? What does it demonstrate, Sid? Can you hear us, Sid?
Sorry, yeah, I can hear you. So I was just trying to unmute my.
Oh, that's all good.
Yeah. So this is the color wave Doppler spectral graph showing the inflow velocities of the mitral valve across the mitral valve.
And it's meant to be pulse wave. It's not the best view in the world, but what is it?
Yeah.
What are we imaging? Which anatomical structure are we imaging?
This is the Can you run the video again?
Oh, there's no video. It's just a still.
It's probably the mitral valve, across the mitral valve, because I don't think it's across the pulmonary.
So if it was the mitral valve, as in across the inflow, which part of the curve would you expect blood flow to be above? Sorry, which part of the cardiac cycle would you expect blood flow to be above the line?
It's diastolic above the diastolic
Nice.
above the line, diastolic above the line. But this is diastolic above the line, so this is probably the mitral valve.
And what shape would you expect it to be in there? Sorry, I just withdrew it.
Because color wave is a pulse wave, so
yeah, it's meant to be pulsed wave, and if it's a bit hard to see, but the pulse wave is actually right down at the bottom of the left atrium.
Yeah, that's what I was trying to see, whether it's a pulmonary vein or whether it is a mitral. But just because the line, it is going to be a continuous line, it's going to be very hard to figure out whether it's across the pulmonary vein or whether it is a mitral valve.
Yeah, and it's just meant to be pulsed wave Doppler in that pulmonary vein.
Yeah. Okay. All right. So what it is showing is it should be S and D wave. So there is more of a diastolic prominence of across the mitral across the pulmonary vein.
Nice.
So maybe a severe mitral regurgitation.
Good man, good man. And raised left atrial pressure. And here we've got systolic flow reversal, I think is what I was trying to demonstrate in this.
Yeah, okay.
But again, it's not the best one. And the last thing I was trying to look at with this was to look at often one of the signs of severe MR can be an E wave greater than 1.2 or 1.3. Right. We didn't really see that with this one, but it's what I was looking for and just trying to remind people that assessing for MR severity, use every little trick you've got and don't forget about the big E wave because you've got so much blood coming back into the left atrium, then it pushes it forward into the left ventricle and you have sort of a volume overloaded mitral inflow. Nice one. All right, Hatim, you're still driving, right? Who else have we got online?
I'm back, Sam.
Oh, hey, okay. Have a look at this. Can you look at some pictures?
Yeah.
Cool. All right. So the question is, where is the infarct? Tell me which coronary artery territory you think it is, and tell me whether you think it's acute or chronic.
So this is a 2D image in sinus rhythm at heart rate of 90 of apical 4-chamber view, and I can appreciate akinesia of the septum and the apex of the left ventricle with hypokinesia of the anterolateral wall of the left ventricle. I suspect that this will be an left and LAD territory infarction.
Nice.
And it looks more of chronic because of element of scarring with hyperechoic septum and very thin wall of the septum as well as the apex.
Very nice. And
a small amount of pericardial effusion. Probably I would like to see it from different views to confirm that it's not a fat bed.
Fantastic. Anything else?
And anything else? I can see both back muscles properly, and the mitral valve leaflets, both of them are okay.
What walls do you say? We said we had anterolateral. The other wall is the
infraseptal.
Very nice, very nice. Anyone else? There's something else you got in here. So I said acute versus chronic. So Hatim quite correctly is suggesting that some of those echo features with the thinning and the scarring might suggest chronicity. Anyone think differently?
The LV is dilated, so that could be an indicator of chronicity.
Very nice, right? Very nice. Anyone else?
Thinking there looks like there's a true aneurysm. It's a possibility.
Oh no, there's no true aneurysm. They've just got akinetic, thinned apex. Again, see the whole image. That's what this little trick's all about. What are we missing? There's something else in there to maybe suggest that we've got. So the answer is everything you've said is correct, but this is actually someone who's got acute on chronic ischemia. So they were thought to have further ischemic event on top of chronic event, and that was again, it's a good indication of, for me, of making sure that your echo cannot tell you everything. You've got to use your clinical acumen as well. We've got to look at other things. So what would those other things be? It'd be clinical history, looking at the patient, troponins, and
There's ST elevation on ECG.
very nice, very nice. Don't forget your ECG, okay? Because there's ST elevation, and that was these signs of acute ischemia that was going on in this guy.
This is ecolab too.
I know, but we're also clinicians, not sonographers, and so it's important to see you use everything.
Again, the differential diagnosis for the ST segment elevation could be still an aneurysmal dilation.
Absolutely, absolutely. But you didn't say it. That's the main point. You got to go on with it. Yeah, nice. So, and again, we're sort of coming on to Hatim whilst you're there. What am I doing? So I showed you two other images. Can you see I've moved the, classically, I guess when we're in an apical four-chamber view, maybe you've got the focal point down at the level of the mitral valve. As I'm now moving towards zoomed-in views of the left ventricle, I try and zoom in towards the apex. And this is kind of going to what you were saying about going to have a look for apical thrombi, yeah?
Yeah, exactly. So basically, it's a focused view of the left ventricle of the same patient in an apical four-chamber view. And this is trying to demonstrate whether there are any filling defects across the apex and the apical contraction. So definitely the apex is akinetic, is not moving. I can't see any big filling defects. So probably I'd consider either a contrast study or at least placing color flow across it, and as well pulse wave Doppler and identifying the flows.
And don't forget about off-axis imaging, all right?
And definitely looking at apical 2 and off-axis.
Beautiful, good man. Okay, so Hatim, while you're still there, we've got 84-year-old guy, collapsed hypotensive, history of diabetes and a smoker. On examination, he had this really cool hand, which had reduced cap refill, and you can see it's pretty blackened towards the tip of the fingers. All right, might just skip through this bit just in the meaning of time. Let's go through it again. So we've got a similar kind of appearance that we've had with apical akinesis here. And here's your two-chamber. Talk to me what you can see in this, Hatim.
So an apical two-chamber view with a sinus rhythm at heart rate between 60 and 70. I can see a global reduced left ventricular ejection fraction with regional wall motion abnormalities. That would be consistent with an apical nearly akinesia, as well as the posterolateral septum and posterior wall are both.
So this is meant to be a two-chamber. So what's the wall on the left?
So this is the posterior wall.
Yeah.
And that's the anterior wall.
Yeah, so classically, I guess we call it the inferior. I think posterior is more can be called for the infralateral wall or posterior. So just try and keep, I think they're normally calling it inferior. So just inferior and anterior probably is more correct.
So the inferior wall is relatively hyperechoic with probably a scarring tissue there. And again, most of it is akinetic. I can see some trabeculations across the left ventricular apex, and as well probably some on the free wall. Mitral valve is not contracting that is not opening that well, and the anterior wall as well is relatively hypokinetic. So
What do you want to do next?
So I would like again to confirm what's exactly happening across the apex and what's happening across these trabeculations. I would like to get a color flow across it, and then after that I would put the pulse wave as well to demonstrate the flow.
And off-axis imaging, don't forget about that.
Yeah, and again, getting different images.
With the standard views, we may have missed it. If I just go back to the two-chamber here. So here on the two-chamber, a couple of things. Can you see the SEC, the smoke that's coming through the top of the LV, obviously indicating sluggish blood flow, and just coming in every now and again, there's this.
This appears hyperechoic.
Got it. You got it.
Yeah, 1 by 1 centimeter, more likely consistent with an apical thrombus.
Very nice indeed. So don't forget about that off-axis imaging. So guys, so a quick run through, I guess, of everything. Obviously, a few more cases we could have gone through, but in the meaning of time, I might just leave it at that. Just, I think in conclusion, this is super common to have to look for regional wall motion abnormalities and look for acute ischemia in the critically ill. Clinical acumen is really important before you get to the bed space about what you're looking for. Examples being, if it's acute deterioration 3 days down the track from something, we'll look for the rare things as well as systolic dysfunction, right? So don't forget to look for the PAP muscle ruptures, the VSDs. If you've got someone with acute ischemia or cold hands, with sluggish blood flow and apical akinesis, don't forget to go off axis looking for the thrombus. So you're going to need multiple views to assess each of the segments. I use the 16 segment model, as I said, and try to have a look at each segment at least twice. Apical akinesia, we mentioned multiple times, use off-axis imaging and contrast. And I guess also don't forget about subcostal imaging for off-axis imaging. That's always useful. And the final thing, as we said again multiple times, echo does not rule out ischemia. It's just there as an adjunct, and I think you need sort of multi-modality assessment. And that's about it, really. Are there any questions?
Thank you, Sam. Very
pleasure. Thanks very much, guys. See you next week. Benny's going to be talking about...
Well, do cardiac masses half an hour, cardiac masses half an hour, and ASDs.
Perfect. Enjoy cardiac masses and ASDs. Nice one. Thanks very much, guys. See you later. Bye.
See you.
Thank you, Sam.
Okay, bye.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.